Chodo, let's start with the endocrine system. Now, the first organ we'll be discussing is pituitary. There are five. I'll make five separate videos for that. So, first is pituitary. Pituitary is connected with hypothalamus with the help of pituitary stalk. The hypothalamus is going to secrete certain hormones which are going to travel via pituitary stalk and activate your pituitary. Now, pituitary is divided into two parts, the anterior and the posterior. Anterior pituitary is called as adenohypophysis and posterior pituitary is called as neurohypophysis. The hormones which are being secreted by the hypothalamus to come to the pituitary, which are traveling via pituitary stalk, in the anterior pituitary, it comes via arteriovenous bundle. So arteriovenous bundle, anterior pituitary, adenohypophysis. सब कुछ AAA है. And in the posterior pituitary, it is called as neurohypophysis because the hormones they are reaching here, the signals they are reaching here with the help of nerve bundles. So neurohypophysis. How many total hormones are coming from pituitary? Seven. So how many signals are going to come from the hypothalamus? Seven signals. So this HPA axis, we have learned this in the classes. First was your GnRH coming from the hypothalamus. Then FSH-LH from the pituitary and it works on the gonads. Second is CRH from the hypothalamus will help in secretion of ACTH, which will work in adrenal cortex. Third is TRH. It will help pituitary secreting TSH, and this TSH is going to work on the thyroid. T3 and T4 will be secreted. Fourth is DOPA, which has negative effect on pituitary, will not allow the secretion of prolactin by the pituitary. Where does prolactin work? Target organ is mammary glands. Then growth hormone, GHRH, growth hormone releasing hormone by the hypothalamus. GH will be secreted by the pituitary, and then it works everywhere, predominantly in the liver. The neurosecretory cells in the hypothalamus, they're going to secrete the signals. They're going to travel via the nerve bundles and will activate your posterior pituitary, which will secrete two hormones, ADH and oxytocin. Oxytocin work on the mammary gland and ADH works on the kidney, antidiuretic hormone, kidney. If there's a damage of the pituitary stalk, all the hormones coming from the pituitary will get low, except prolactin, because DOPA will not reach. And DOPA has a negative effect over the pituitary in releasing of prolactin. So prolactin will rise. Whereas if there's a pituitary damage, all the hormones from the pituitary will decrease. And this is called as, this is seen with Sheehan syndrome, which is postpartum hemorrhage, where the BP decreases and patient goes into hypotension, leading to pituitary ischemia. ठीक है. Which part of the pituitary will be more commonly damaged? Anterior will be more commonly damaged as compared to the posterior. Now, pituitary, seven hormones. First is FSH-LH. Second is your ACTH. Third is TSH. Fourth is prolactin. Fifth is your growth hormone. And two from the posterior pituitary, that is your ADH and oxytocin. So these are the seven hormones coming from pituitary, five from anterior and two from posterior. There are four diseases which we'll be discussing here. First is high prolactin, prolactinoma. Second is high growth hormone, acromegaly. Third is high ADH, that is SIADH, syndrome of inappropriate antidiuretic hormone, and DI, that is your diabetes insipidus, which is due to decrease in ADH. Okay. Prolactin increase leads to prolactinoma. This is the most common functional tumor which we have. Prolactinoma can be of two sizes. Small size increase in the pituitary gland, less than 1 centimeter, microadenoma, more than 1 centimeter, macroadenoma. Why would prolactin rise in the body? Either a patient is having an hypothalamus injury or a dopamine blocker drug, or maybe pregnancy in which the prolactin rises physiologically. Any pregnant female having high prolactin, should we be concerned? No, if the female is asymptomatic. But if the female is symptomatic, which symptoms? Headache, visual disturbances, because pituitary gland increased size will compress the optic chiasma, can cause visual disturbances. When the size of the pituitary gland increases, brain occupying lesion increases the intracranial pressure and tension, leading to increase in headache. If these symptoms are seen in a pregnant female, take the female directly to MRI room and see the exact location and the size. What is the investigation of choice? MRI. What is the screening test in a pregnant female for suspecting prolactinoma? Visual disturbances. What is the drug of choice? Bromocriptine. And if bromocriptine is not helping in relieving the symptoms, do the surgery. Another reason for hyperlactin, hypothyroidism. I told you whenever there's a hypothyroidism, there will be indirect increase in the prolactin levels because hypothyroidism will lead to increase in TSH and increase in TRH. The hypothalamus, when it is increasing more TRH, it's secreting more TRH, it indirectly increases the prolactin. So just learn hypothyroidism can lead to hyperlactin. If there is hyperlactin, there will be negative effect on GnRH. That means it will reduce GnRH. If the GnRH is reduced, it will decrease LH and FSH. And if LH and FSH is decreased, I mean, you can understand LH androgen will be decreased and male infertility will be seen. And with FSH, it will be estrogen decrease, which will lead to menstrual disturbances. Okay, which can lead to both oligomenorrhea or menorrhagia. Now, the most common finding with hyperlactin is galactoria. Investigation of choice for growth, I mean, pituitary adenoma, and adenoma which is leading to prolactin rise is MRI because it tells us the size and location. If it's a pregnant female, bromocriptine is a drug of choice. If it's a normal individual, not a pregnant female, then you give cabergoline. And if giving these drugs does not relieve the symptoms, we do surgery. Then acromegaly. Acromegaly is due to increase in the growth hormones. Growth hormones are produced by somatotrophs. And this is the second most common functional tumor coming from pituitary. Growth hormones have got five function: muscle size increase, cardiomegaly, sodium water retention, hypertension, activation of liver, increase of insulin-like growth factor, which blocks the insulin receptors, so you are not able to manage the sugar levels, diabetes mellitus. This is the most common cause of death in the patients of acromegaly because all three combined are called as ischemic heart disease. It also decreases the insulin sensitivity, leading to diabetes mellitus, and it activates every part of the body, leading to increase in size. So in growth hormone adenoma, सब कुछ बड़ा. ठीक है, यही अपने को याद रखना है. Facial signs are seen very early because face ही सबसे पहले दिखता है. So frontal bone protrusion. Then mandible will be more enlarged, so it will come out. Prognathism, gap bite. What is the screening test? IGF-1 levels. देखो इसमें सब बड़ा है, ठीक है? IGF-1 levels. If IGF-1 levels are normal, it is not acromegaly. If it is high, then you do OGTT, which is treatment of choice, investigation of choice. And once you are sure it is acromegaly, take the patients for MRI and see the location and the size. If you can remove it, remove it. In pituitary adenoma, which is leading to high prolactin rise, matlab prolactinoma, I said give the drugs and try to get out of the symptoms that the patient is coming up. But in growth hormone adenoma, I'm saying if you can remove it, remove it. If you can't remove it, then give somatostatins because somatotrophs are the cells which are going to secrete growth hormone for us. In this patient, there's too much of growth hormone, so we give somatostatins so that no growth hormone is released further. And whatever growth hormone has come in our blood, we do not want this growth hormone to function. We do not want this growth hormone to go and attach to different cells. So we give growth hormone receptor blockers like pegvisomant. Remember the drug lens you tried? This is a somatostatin. Okay. Then your SIADH. In this, the ADH increases. Anti-diuretic. What do you mean by diuresis? Diuresis matlab increase in loss of the blood. Matlab blood increase in the loss of water in the urine. This is diuresis. So if there is more water coming in the urine will be diluted. So D for diuresis, D for diluted urine. Anti-diuresis matlab no dilution of the urine. That means concentrated urine. So whenever ADH is more, ADH is working on the V2 receptors of the kidney, it absorbs all the water inside the body and the urine becomes very concentrated. Whenever you are losing more water in the urine, normal water loss is 0.8 to 1.52 liters. ठीक है जितना यूरिन हम करते हैं बट if somebody is urinating more than 3 liters in a day, you call it as polyuria. And polyuria can be of two types, primary and secondary. Primary polyuria is because the patient is drinking a lot of water, and that is why the patient is releasing a lot of water. Secondary polyuria means diabetes insipidus. How do you differentiate? Beta, you see the urine osmolality. Osmolality matlab गाढ़ापन, matlab concentration. So if the patient is having polyuria, so already the concentration is decreased. Where it is primary polyuria or secondary polyuria, both the concentration will be less. But in primary polyuria, patient is drinking a lot of water. So where is this water going? This water is actually making the serum, the blood, the plasma osmolality to be decreased. So in primary polyuria, both the osmolalities are less. The urine osmolality because there is too much of water coming out in the urine, and plasma osmolality because there is too much of water in the blood because the patient is drinking too much of water. Whereas in secondary polyuria, the patient is having polyuria. So urine osmolality is less, but the patient is not drinking too much of water. So from where this water is coming in the urine? From the blood. So what does the blood becomes? Thick. So osmolality increases. Okay. Now we are talking about ADH. If the ADH is more, all the water is coming in the blood vessel. The urine becomes very less, very highly concentrated urine because all the water is inside. If all the water is inside, Chodo, it increases the cardiac load, it increases the blood pressure, which is not good for the body. I want to release it. So when there is too much of cardiac load, when there is too much of blood pressure the patient is having, there happens a secretion of ANP. Natriuresis. Natriuresis मतलब सोडियम बाहर निकालना है in the urine. So आपको पता ही है with sodium water comes out. So body secretes increase ANP. This increase in ANP will block RAS. What is RAS? Renin, angiotensin, aldosterone system. What is the function of renin, angiotensin, aldosterone system? To absorb more water. Aldosterone works on the ENaC channel, absorb more water and salt. But यहाँ तो already water is inside the body. So you want to release it. So you want to block RAS. So you secrete ANP, you block RAS. Aldosterone will not work. So there will not be any sodium and water retention. It will all go into the urine. So your patient in the start was having hypervolemia because all the water was inside. But now you have blocked aldosterone. So all the water is getting lost. So your patient is going into hypovolemia. So from hyper to hypo, patient becomes euvolemic. Volume balance हो जाती है. But because you are losing a lot of sodium, so patient becomes hyponatremic. So the problem with the patient is hyponatremia, euvolemia. And all the symptoms of SIADH will come because of hyponatremia only. And you have to manage hyponatremia. That's what the scenario is. Now, osmolality की अगर हम बात करें concentration in SIADH, urine osmolality very high osmolality concentration, whereas volume of the urine very less concentrated in blood. All the water is inside, so volume is high, but the osmolality concentration is very less. Investigation of choice is water loading test. If I give you a lot of water, your ADH will not work because you want to release this water. But in this patient of SIADH, if I give more water also, it doesn't bother ADH. ADH will keep on working more. That means ADH is not working for us. ADH is on itself working. Now, treatment, if the patient is asymptomatic, just follow up, but fluid restriction will be good because too much of fluid inside the body. But if the patient is symptomatic, give Aptans, V2 receptor blockers. Okay? डायबिटीज इंसिपिडिस दो तरीके की हो सकती है छोटू सेंट्रल नेफ्रोजेनिक सेंट्रल में पिट्यूटरी डैमेज सो इफ द पिट्यूटरी इज डैमेज्ड यू आर नॉट हैविंग एडीएच if you're not having ADH you'll not be able to absorb water back in the body so patient will have polyuria diabetic insipidus nephrogenic type problem in the V2 receptors so kidney is not working pituitary will keep on saying भैया क्यों पानी बाहर जाने दे रहे हो it will increase ADH so how do you differentiate between nephrogenic and central diabetes insipidus with the help of ADH because if it is diabetes insipidus, it is polyuria. That means urine osmolality will be less. Urine तो बहुत ज़्यादा पतला होगा. So urine osmolality कम है. But if it is central, ADH also will be less. If it is nephrogenic, ADH will be high. Hmm? For central diabetes insipidus, you are giving desmopressin, and for nephrogenic diabetes insipidus, you are giving thiazides. This is your diabetic insipidus. So this is all about pituitary. I'll see you in the next video. That is thyroid.